Welcome to today's workshop, which is on hot topics in consent for research, where we'll be focusing on AI and clinical trials. My name is Sumitra Menon. I'm the Deputy Director at the Center for Biomedical Ethics, and I'm also the Program Director at SHAPES. Today's workshop is organized under SHAPES. So we've got two sessions, which is split by a tea break. And the first session will be chaired by my colleague, Dr. Owen Schaefer, who is an assistant professor with the Center for Biomedical Ethics. Owen, can I please hand it over to you?
Sure. Hi, so just to introduce our first speaker of the first session, and then Julian will have about 30 minutes. Professor Julian Savulescu is the Chen Centennial Professor of Medical Ethics at the National University of Singapore. He has many prominent achievements, scholarly works that you can read about a bit on this bio and on our website. In the interest of time, I'll just say he is well trained in medicine, ethics, and philosophy, and I'm very interested to hear what he has to say about consent GPT. Julian?
Yeah, it's great. Pleasure to be with you. So I'm not going to directly talk about clinical trials. I'm going to talk about some work that we're doing around using large language models to obtain consent to surgical procedures. But it's directly transferable to the issue of obtaining consent in clinical trials. And along the way, I'll make some direct references to clinical trials. So this is largely the work of my PhD candidate, Jemima Allen, who's in the final year of medicine, and she's doing a PhD with me here at NUS, and Dominic Wilkinson at Oxford, and she's enrolled at Monash, so it's a very interinstitutional PhD. And I want to look at whether it would be ethical to delegate medical consent seeking to large language models. And this would include in research studies. In fact, you know, the arguments that I'll give will apply directly. So just to begin, let's start out with a hypothetical case. This is an 11-month-old Oscar and his mother, Sarah. So Oscar has presented with a history of poor weight gain, and after appropriate clinical review and some initial blood tests, his paediatrician wants to proceed with an endoscopy to confirm Oscar's diagnosis. Oscar's mum is a little anxious about the procedure and wants to know more before it all goes ahead. After explaining to Sarah that the indication for endoscopy, Oscar's paediatrician sends her a link to an AI-powered app called Consent GPT to explain the details of the procedure, and Oscar's paediatrician will then do a final check on the day of endoscopy to make sure she's still happy to go ahead with it all. Back at home, the app explains the relevant procedure to Sarah, and including the risks and benefits, and answering more specific concerns that Sarah has. So it then proceeds with a transcript of the whole conversation that both Sarah and her paediatrician can retain. So would it be ethical to delegate medical consent to large language models in this way? Now, obviously, this is a hypothetical case, but looking at more at the status quo in medical practice and in research practice, it's not an entirely new concept. In fact, it's quite common for the middle part of the consent procedure to be delegated to other members of the team who are not performing the operation. This is typically junior doctors, but can be a research nurse or some other member of the team. And in a paper that Jemima and Dominic have already published in the Journal of Medical Ethics, they call this middle section procedural consent, in which the relevant information explained to the patient and documented. The reason this process is delegated tends to be because surgeons, or indeed principal investigators like me, are especially busy and don't have time to talk to all patients and participants and answer all of their queries. So it's delegated to a qualified healthcare personnel who can stream clinical workflow. And then there's a final check, either in this medical case by the surgeon. But while consent may be delegated with the best of intentions, we know that this process or this procedure is far from ideal. Firstly, for a number of different reasons, junior doctors often lack the training and supervision to seek consent properly from patients. They may face competing clinical demands themselves and time pressures which could compromise the consent-seeking process. And it often gets reduced to a signature at the end of a very lengthy document. Secondly, patients' decision-making capacities may be restricted by their own views, biases, or psychology, either rightly or wrongly. A systematic review of patient-clinician experience of the informed consent process in surgery found that some patients may feel rushed by their doctors, or they don't want to waste their doctor's time by asking questions. Some describe this desire as the desire to be the model patient, that is, one who's complacent and compliant with medical advice. Obviously, this can be particularly unhelpful when it impacts on the voluntary and informed nature of a patient's consent. Finally, another concern is that surgeons often can't agree amongst themselves on how much information it's relevant to disclose before surgery. A systematic review and meta-analysis of perioperative consent conversations found there was high variability amongst surgeons regarding what risks were necessary to meet the requirements of informed consent. This is particularly worrying given that failing to mention a complication in a treatment is the most common reason for a complaints process involving consent. These compounding deficiencies around the current consent process not only risk compromising patients' consent, but also undermining community trust in doctors and leaving doctors legally liable. There are many ways we might address this problem, but one possible solution is through the use of AI and in particular large language models like ChatGPT or Claude, programmed with information relevant to a particular procedure or clinical trial, and use these to seek consent from patients before an operation proceeds. Specifically, they could replace junior doctors or the clinical trials nurse in the procedural consent process. This has a number of pros and cons. Chief among them is the notion that they could be used to enhance informed consent by improving patients' understanding. It could also be used to improve access to information and tailor that access according to the patient's desires and needs. ChatGPT has infinite amounts of, or near infinite amounts of time to spend with the patient and respond to their particular concerns. So the resource limitations, which are inevitable when using human beings, including research nurses or junior doctors, are not present when we use large language models. There are obviously important risks related to hallucinations in these systems. In my experience, when ChatGPT has been trained on a particular corpus of information, these hallucinations are not common, although this is obviously an empirical issue. There are also important considerations for doctors and health systems. So large language models could achieve these things in a number of ways. For example, it could adapt the language based on the patient's literacy level. Take, for example, these two explanations of the endoscopy procedure from the case earlier, one pitched at the age of an 8-year-old, the other pitched at the age of a 12-year-old. But it could be pitched at the level of a university professor, if that's what you wanted. So there's no longer one size fits all. There are already a number of studies which look at the technical feasibility of using large language models in medicine. Most of these studies compare the mechanical features of AI with human clinicians, looking at clinical accuracy and patient satisfaction, which are important key performance indicators. However, so far there's only been one clinical trial which compares ChatGPT with human clinicians in the consent process. This study, which was conducted in early 2023, looked at the use of ChatGPT to obtain informed consent prior to coronary angiography. The researchers found no difference between the groups regarding satisfaction, but patient understanding was higher significantly with the AI group, the group using ChatGPT. But while these studies look at whether it's technically feasible to use large language models, they lack consideration of other underlying ethical principles other than ensuring understanding, which might govern their clinical uptake. So in the paper I mentioned in the Journal of Medical Ethics, Jemima and Dominic and others discussed some of these ethical issues. I've already mentioned accuracy. Before something can be rolled out clinically, it will be important to ensure its medical accuracy, that is, it's transferring the correct information, especially regarding the risk of hallucinations. However, as I said, it looks like these hallucinations are much less common with more recent models, and they're much less common on models that have been trained to on a particular corpus of information. Secondly, privacy. It will also be important to ensure that patients' data is kept private and confidential, like any other medical record. Trust. It will be important to look at how this might impact patient trust. The one study that's been done has found that patients are satisfied, but that's clearly just one study. On the one hand, lack of human interaction in interpersonal relationships could corrode the doctor-patient relationship. On the other hand, the large language models could empower patient decision-making and strengthen trust in their doctor. Responsibility is another issue. Some are concerned that this will, about who will be responsible if something goes wrong when a large language model is used. But just like when consent is delegated to junior doctors, in this case, the treating surgeon will remain ultimately responsible for the consent process, and so those who design the clinical trial. Legal liability and material risk. Following the legal shift to a disclosure of material risk, both in Australia, the UK and now Singapore, these models could be programmed with open-ended questions to determine information that might be important. In fact, establishing these answers to these questions may help inform human consent delegation as well. Additionally, it may even be possible to tailor Consent GPT to an individual's own values and preferences. Consent GPT could potentially predict and personalise information that would likely be important to the patient. And I'll discuss that in more detail at the end when I talk about models of the doctor-patient relationship. One concern is that click-through consent, with click-through consent, patients may be less engaged when it's delivered online than in person. And this, of course, is an important empirical issue to address. This concern relates to people's tendency to click through or scroll through digital consent forms simply to get to sign on the bottom line without properly understanding or evaluating the information. But it may be possible to address all these concerns about patient engagement by designing large language models to use simpler and more engaging responses, and indeed to gamify the process of obtaining consent. We all of us with children know how addicted our children are to games. That now you could in fact get patients or participants to be addicted in a way to engaging in the consent process, which may be a positive outcome. So there are, I think, many ways in which we could use cutting-edge technology to improve what humans are doing and restrict their limited resources to things that only humans can do. So currently we have a project with NIAM in NUHS that's looking at not only looking at the accuracy and satisfaction of patients with using Consent GPT, but also looking at these other ethical parameters of the interaction between the patient and the large language model. So Niam's team is training a version of ChatGPT-4, around particular procedures, for example, surgery for breast cancer, feeding in guidelines and relevant papers, and then using that as a surrogate of junior doctors to obtain consent for particular procedures. However, we're aiming to piggyback on that study to ethically evaluate these interactions beyond just whether patients understand and it provides accurate information. So the project that Jemima is working on has three aims. Firstly, to ethically evaluate the implications of using large language models, to refine and evaluate ethically justifiable large language models for use in clinical practice, and to develop a framework for the safe and effective implementation. So, as a part of the first aim to evaluate the ethical implications, we're doing a survey, a large survey which will build on existing work, looking at the public's views around the issues related to using large language models in medical practice. We'll evaluate also the use of large language models to obtain consent in research, and assess the requirements for assessing patient capacity, understanding and disclosure of material risk. So, one of the concerns is that when you have a large language model, it can't evaluate the patient's either capacity or whether they're acting under duress or from pressure from family or other coercive influences. So we have a number of ways in which we're thinking about testing whether large language models can address this. One is to kind of create or role play with medical students or even professional ethicists, simulating a patient with a cognitive impairment and seeing whether the large language model can be trained to pick up the patient's lack of understanding or incapacity. We are also thinking about training a different large language model such as Claude to be a patient with a certain set of characteristics and use that language model to test the candidate model obtaining consent. So kind of war of the large language models. So there are many opportunities for not only kind of novel procedures but novel evaluation. And we're also aiming to explore the use of this in paediatric settings where you have younger patients and looking at the quality of their consent. So as I said, we've Jemima and Dominic and Brian Earp, who will be joining us, have already published one paper looking at the theoretical issues and a proof in principle that you could use this. So we have a kind of clear methodology, and we're just about to start testing the model that Niam has. So we've as I said, we've produced one publication and recently a conference abstract. So I think this is one use of large language models that personally I think will take off in medical practice, and within research practice. One can see the advantages of using this rather than a human individual to obtain consent. But it's important to trial it to see whether it's superior to the status quo. Okay, so I think I have a few more minutes. I wanted to talk about something else that's also relevant, and this is another paper we've just sent off of using large language models to enable the patient to choose the kind of interaction that they want to have with the doctor. And again, this would apply with the research setting. So some of you will be familiar with this. Ezekiel Emanuel has described these 4 different models. I have a different description of the models, but we don't need to go into my particular contribution to this debate for this talk. He describes 4 models of the doctor-patient relationship. The paternalistic model, where the doctor decides what's best for the patient. The informative model, where the doctor provides information and the patient decides. The interpretive model, where the doctor helps the patient clarify their own values to make an informed decision, and the deliberative model, where the doctor engages in dialogue and may actively persuade the patient towards suitable options based on the patient's values, though at times the doctor can challenge those values, because clearly sometimes we can be mistaken in our valuation of different options. A person who prefers to smoke, and values smoking, may be said to be, mistakenly, overvaluing the short-term pleasures and rewards of smoking versus the long-term, rewards of interaction with their family, health, etc. Each of these models has different downsides. For example, the interpretive model risks the doctor unwittingly imposing their own values. The deliberative model risks the doctor persuades the patient too much towards some narrow health-related outcome without taking into sufficient account the patient's broader values. Now, personally, I think the deliberative model is the best one, and I think we should focus on refining that model. But in the paper, we say we can let the patient decide which model they want to have. So after some initial discussion about their values related to the doctor-patient relationship and what's important to them, the patients can choose which model. So the same thing could apply to research. The patient could articulate certain values around the interaction, and the nature of the large language model would be chosen to fit that patient's desires. They may be, as I said, the primary means of communicating information between patients and their condition. So, again, we did some empirical research generating dialogues with different models and calculated the inter-rater reliability with an external code-up. So, here's an example of the coding for the informative model. We discussed explaining diagnosis. The doctor provides clear, comprehensive information about the patient's diagnosis, and answering the patient's questions. The doctor responds to the patient's questions, inquiries with comprehensive understanding of the information. So an example of coding the deliberative model. So whereas the informative model doesn't encourage, for example, reflection on the patient's own values, in this, the doctor prompts the patient to reflect on their own feelings, beliefs, and values, and I would argue, is able to challenge those values. So here's an example of a case that I had in my own 1990s article around what I call at the time rational non-interventional paternalism, where a woman is at risk of developing breast cancer due to a BRCA mutation, and her doctor recommends double mastectomy. However, her husband is attached to her physical appearance, and it's a big part of their sexual life. And she's worried that if she has a double mastectomy, he will lose interest in her. So the deliberative communication style would involve challenging the weight that she puts on her physical appearance versus the sort of long-term health risks of retaining the breast tissue and having surveillance. For example, the ChatGPT finishes with, given your fear, it seems essential to talk with your husband. Conversations like these can reveal the strength of your emotional, intellectual connection beyond your physical attributes, but let's also reflect on the primary reason for considering the surgery, your health, your life. Have you thought about prioritising your health, what it means to you? So this is in contrast where, the informative style, this is a transcript of the interaction, and the doctor just presents information to the patient. So this is an example where you could construct also more choice for the patient around the way in which information is delivered. As I mentioned, the different media that could be used, gamification or simple dialogue or an avatar. So each of these, the patient could have a choice both in research and the clinical setting. So I haven't talked at length about the risks of these different modalities, but I've talked about the ethical upsides. And the ethical upside is not just greater satisfaction, but actually achieving an interaction that enables the patient to choose the option which best coheres with their values, and maybe even revising their values in light of ethical argument. So let me finish there and pass on to Joel.
Joel Seah is my PhD student here at Center for Biomedical Ethics. But he comes into our program with a wealth of experience in the IRB world, so his talk will be well informed by practice. He's worked as secretariat for various IRBs at NHG, SMU, and NTU. And so, yeah, I think that this talk is going to be very useful in terms of understanding how AI can practically be used in the research ethics ecosystem. He's also a member, I'll just mention, of the Consortium to Advance Effective Research Ethics Oversight, the AREO Consortium. That's a US-based consortium. This is a sort of topic. It's not just here. It's in the US and around the world. There's a lot of interest in leveraging artificial intelligence at various points in the research ethics oversight process, from the researcher to the IRB secretariat side. His PhD explores these areas more broadly, but today we're looking more specifically, I think, at drafting of consent forms using AI. Okay, Joel?
All right, so thank you very much, Owen, for the introduction. So Julian has spoken to you about Consent GPT, essentially, how you can use Consent GPT to augment that interpersonal exchange of information as well as intent. But today I'm going to speak to you something a bit more fundamental about how you can use GenAI in the drafting of consent forms. So I'll be framing it specifically in the context of consent form for research participation, but you can see whatever I'm going to say could also be applicable in the clinical context as well. So for example, consent for medical procedures like surgery. Okay, so I'm pretty much sure that everybody would have at least heard, seen, or perhaps used one of these large language models. And in terms of your attitudes, perceptions, or perhaps even intuitions on AI, you could find yourself in one of these three categories. So for one, you might be finding yourself quite averse to AI or anti-AI, that you think AI shouldn't be involved in any activities that's humanly intrinsic in nature. So for example, like writing, acting, drawing, or perhaps even driving. So that's one end of the spectrum. You could have the other end of the spectrum where perhaps you are very much pro-AI, or perhaps you're even an AI advocate, where you can say, AI should be applied to solve all our human issues, all our human problems. Why? Because AI is presumably much smarter or better than humans. They are less prone to make mistakes. They are not swayed by emotions compared to humans, or perhaps they're even more empathetic compared to, for example, say medical doctors. So you think that AI is really good, AI is quite accessible, let's use it to solve all of humanity's problems. Or perhaps then the majority of you in this room might be finding yourself smack in the center, where you are saying that you've heard and seen all the great benefits, but you've also seen all the relevant risks and the limitations of AI, and then you ask yourself, is AI really that good? You are wondering, should I be involving AI in my daily life, in my daily work? So regardless of whatever groups you may identify yourself with, I hope that at the end of the presentation you'll be convinced, as much as I am, that we ought to actually, in the primary interest of research participants, to be using GenAI to develop our consent forms to help enhance understandability and readability. But obviously, there are certain considerations and caveats in place, so perhaps we shouldn't be using AI to have full reign over the consent process. So this is going to be an overview of what I'm going to share today. So why such fuss over informed consent? What are the current issues and challenges with informed consent forms? And lastly, is GenAI a silver bullet? So why is consent so important? And why are IRBs or research ethicists so obsessed with informed consent? May I suggest to you two aspects, the legal as well as the practical and ethical. So for the legal aspect, we've got things like soft laws, principles, and guidelines, as well as hard laws in terms of regulation for human subjects research. So I'm pretty sure everybody will have heard of the Nuremberg Code by now, coming off from the Nazi trials, which essentially says that if you want to do medical experimentation, you need to get voluntary consent. That's completely paramount. And what that means is that the person who's going to be involved in the study, he or she needs to have sufficient knowledge and comprehension so that they are able to make an understanding and enlightened decision. So that's the Nuremberg Code. We also have the Declaration from Helsinki developed by the WMA, which essentially much says the same thing. So you need to get freely given consent, and the person has to be informed and explain about the nature, purpose, and risk of clinical research. And we've also got the Belmont Report, which I'm pretty sure everybody will be familiar by now, essentially as enshrining these ethical principles for the ethical conduct of human subjects research. So things like beneficence, justice, and respect for persons, which essentially say that every individual ought to be treated as an autonomous agent. And what that means is that you need to get voluntary consent and you need to give the person adequate information. So you find that the US Common Rule has pretty much coded these principles into their regulations for human subjects research. So pretty much the same thing. They're saying that you need to get informed consent, and they also go on to say that the information provided in the consent form must be in a manner that's understandable to the subject. And in the US, so they've kind of recognized that consent forms can be pretty long at times. So they have this section called the key information. As the name suggests, it pulls out all the pertinent key information about the consent, about the research, and puts it on at the front page. So basically, this is what they say, that the information there has to be both concise and focused, and presented in a way such that it facilitates understanding. And it's not just in the key information section, it's also in the whole consent form as well. So this is what it says, that it needs to provide sufficient detail that's both organized and presented in a way that facilitates understanding. So what this means is it's not just sufficient to have individual sections to be clear in and of themselves. If you bring them on a whole together and the participants reads it and it finds that he or she is not able to understand what's going to happen in the research, then that's just not meeting the requirement. So that's for US Common Rule. We also have the ICH GCP as well, an international standard for clinical trials, which essentially say that you need to get voluntary consent, and the person has to be informed of all pertinent aspects of the research. And they also go on to say that the language must be presented in a non-technical and practicable, and as well as you want to make sure that at the end of the day it's understandable to the participant. So that's pretty much in terms of the international space and as well as in the US. So what about in Singapore? What do we have? So you've got the HBRA, which all of you will be familiar by now. And what it says is you need to get consent. If not, you cannot involve the person in your research project. And they also go on to say about the 12.1 and 12.2 elements, which essentially state, these are all the set of information that you need to provide. So things like what's the purpose, what are the benefits, risks, so on and so forth. And you realize, that's quite a lot of elements from A all the way to Q. That's like 17. And we also have the clinical trial regulations, which pretty much says the same thing. And then also this list of elements as well, which is pretty much similar to the HBRA, but it's from A to U. And again, that's like 21 elements, which is something that I'm going to talk about later. But you can see, perhaps this is why consent forms are so long, right? Because regulators require you to put so many elements in the consent. Now, just to take note, while our local laws say that they regulate biomedical research, I'll go on to say that there's nothing distinct or significant about social behavior research that you would say that, whatever ethical requirements that's in biomedical research, that's not applicable to social behavior. I would say, no, that's not quite the case. You will find that they will be more or less similar. So I've covered on the legal aspects. Now, what about the practical aspects or the ethical aspect? So for researchers, consent is important for you practically because it's just going to help you facilitate the better conduct of your research. And why do I say so? It's because that's actually interrelated with, consent. Why consent is so important for your human participants, both current as well as prospective participants. So for example, if your consent is done well, your participant will actually be able to understand better what your research is all about, and they will also know what are their commitments as well as the responsibility in the research. And you can see how that flows in terms of you'll be able to collect your data in a more smooth manner. That's going to be very likely a lesser possibility of dropouts, and also at the same time, you're going to prevent and reduce all that misunderstanding, and therefore, that will also lead to a likely chance of lowering possible complaints from participants. So that's the practical aspect. But what about the ethical aspect? I would say that you want to do this at the end of the day because you would want to secure and maintain the trust of your participants as well as society in general in the research team and overall research enterprise. I'm pretty sure every researcher out there, the last thing you will want to hear from your participant is that, oh, they don't agree with what you're saying because that's not what they signed in the consent form when actually, that was written quite explicitly in the consent form, but perhaps because of the language or how it's written, they didn't understand it correctly and then they start to complain. And that's fine if it's just in silo. What happened, if they start to tell all their other friends, their colleagues, their relatives, you've got WhatsApp groups and Telegram groups right now actually for research opportunities. And if they go on and start to complain, tell the people, don't go and take part in this research or from this researcher or worse still from this institution, you can see how that's going to make things very difficult for you as a researcher and for the organization as well as the research community you're in. So that's the practical aspect. So I've covered with you, why is it so important in terms of the legal, practical, and ethical aspect. And you can see, essentially, informed consent is this process where you are trying to communicate and present information in a manner such that it enables the person to make an informed consent. And there are two components to it. One is on the oral side. So basically, there's this verbal interpersonal exchange, which Julian has covered, that there's a possibility that you could have consent GPT in the future coming in to augment that process, or perhaps if the technology even gets better, maybe take somewhat more autonomous role in that process. But then you also have the written portion as well. So basically, this documented presentation of the information that's being given, which will be what I'll be focusing on. And you can see, unlike the oral communication, where unless you have it recorded, this written piece of document is going to exist irrespective of time, place, or whoever, or person, as long as you have that document. And essentially, at the end of the day, the aim of your consent form, what you will want to do is you want to be able to present both important as well as relevant information in a manner that's concise, focused, organized, and easy to understand to enable your participants to understand. And what this means is that you're going to have to find a way to convey complex information that's both simple as well as complete as possible to a wide variety of people from different backgrounds. So that said, why is it that despite our good intentions, easy to understand consent form is really hard to get by? Why are consent forms so difficult to understand? There are many issues and challenges, and I will frame them in these three categories, which is essentially readability, understanding, as well as length. So for one, consent forms are just too long and there are too many pages, and I'm pretty sure everybody would agree with me that the longer the document gets, the less likely you will want to read it and to read it to completion. And unfortunately, this is contributed in part, as I mentioned previously, by legal requirements. So for example, like your HPRA 12.1, 12.2. And unfortunately, that again has a knock-on effect on your IRB consent templates and your sponsored trial templates. Two, sometimes there are just too many details, it's too lengthy or it's not concise because that's just how the research is. In Cantonese, we will say like it's very chong hei or it's very lo so. Basically, it's very long-winded. The way it's being written, it kind of beats around the bush at times. And so that's one issue. And the other issue on the other spectrum is, sometimes there's just insufficient details, or worse still, there are discrepancies. So there's just one part. Then there's also the other part, which is, sometimes consent forms are just way too complex and too difficult to read. And why is that so? May I suggest to you a few issues? So one is it's just not well organized, unfortunately. So for example, your study is quite long. We've got like 5 days worth of research procedures, and it just so happens that all that information is just lumped into one long paragraph. So that's just not easy to read in terms of formatting and organization. You've also got the language being used. It's just too technical, it's too scientific. It's just not matched to the reading level of your research participant. Another thing would be the language as well. It's just too legal or too contractual in nature. I'm pretty sure if you read your consent form templates in the confidentiality section, in the PDPA section, it's just quite a lot of legal words involved. And then another thing, grammatical as well as spelling errors. it just makes things really difficult as a participant to read at times. And you may say, are you sure that's really the case? I'm pretty sure, my spell checker works well. May I suggest to you that's not actually as uncommon as you think it might be. And any eagle-eyed folks, right, you will see that, there's actually some spelling error in my words, professionalism and authenticity. And, that actually calls into question of also, if the participant reads a consent form, there's just too many errors, that they question, one, your professionalism, and also, is this research actually authentic, or is a fake research that's actually out there to get my personal data? And lastly, inadequate expertise, both for researchers as well as IRB staffers. Unfortunately, we are just not trained to write a good informed consent form, and writing a good informed consent form requires skills. So essentially, these are the issues and challenges that currently face us in the informed consent form. And you may be saying to me, well, unfortunately, that's just the way things are. There's nothing we can do about it. For example, like legal requirements, that's just what our regulators say. Yes, perhaps that may be the case, and perhaps we need to have this conversation with our regulators or institutional leadership to say, how should we actually go about, maybe we should reevaluate our consent form to see how we can better help and enhance the understanding of participants. But I'll say, yes, that's good, there's a conversation we ought to have, but then in the meantime, as researchers, as the IRB, I think we still have this obligation to ensure that we should do whatever we can to help make things better for our research participants. And I would say that this is actually not impossible. So this is a study done by Zeke Emmanuel as well as Boyle. And essentially, you can see this was actually done in 2020 and 2021, pre-ChatGPT, which was released in November 2022. And essentially what they did was they looked at 4 consent forms from 4 major clinical, from 4 COVID-19 clinical trials, and this was what they found actually. Overall, it was just too long and too complex. It exceeded a grade 9 reading level, and on average it took 35 minutes to read. And mind you, Zeke has an MD as well as a PhD, so he's not like a common layman, and yet it took him 35 minutes to read. So they thought, okay, let's see what we can do about it. Let's see if we can make things better. And this was what they did. Using just human hands alone, not using AI, they found that they have actually been able to make the text more readable. So they've reduced the length by more than 50%, match it to a level that's grade 7 or grade 8. So, okay, I didn't mention, but grade 9, it's like 14 to 15 years old, so that's secondary 3 to secondary, Sec 2 to Sec 3, and then so 7 or 8, it's like between 12 to 13 years old. And not just that, in terms of reducing the length and making it to a level that's understandable to a primary school, secondary school student, they've managed to actually keep intact all that substantial information that was available in the original consent form. So you can see where I'm going with this. If you can do it with human hands alone, what more can you do with large language models, which I will cover in my next slide. But you may be saying to me, okay, we have large language models, but why should I use a large language model? I've got a human, right? I can get a human expert to write about it. But then again, as researchers, we are always strapped in terms of resources. We are always limited in terms of time, money, manpower, as well as effort. So, that's one advantage about using LLMs, because they are just free and also pretty much accessible to the layman, because you do not need to have some coding language involved. And then you may say, okay, perhaps I have money. I can go and hire an expert writer. Sure, you can do that, but is this writer actually well-versed in the scientific discipline that you are conducting your research in? If he or she isn't, then it's going to be much harder to be able to convey that information. So I suggest to you that actually using GenAI informed consent, it's going to be this lowest hanging fruit that we can use GenAI to help improve the informed consent document. So in terms of large language model capabilities and drafting consent forms, there are a few things that they can do in helping to improve the readability of the consent form. So for one, they can wordsmith. So essentially, they can take really complex language and transform it into something that is simple, concise, yet clear and readable. At the same time, they can help demystify technical jargon into layman language. And lastly, large language models are also getting better. They can help transform text into images so that they can help you provide visual description of your research procedures. So all in all, you can see that large language models are going to be able to help you as researchers as well as RRB staffers to be able to create a consent form that is concise yet sufficiently detailed and readable. So that's basically what LLMs can do. But then, you may think, okay, that's really good, and I would say then, how are you going to assess that? And in the past, I would say to researchers, why not you get a third-party member who's not involved in the study team to review it, or perhaps you want to get a family member or a friend who isn't well-versed in your field of study, and then let them assess it and let them see what they say and say, yeah, that's good, but that's still a subject assessment. And so what I would say, one thing you should do is actually to then use objective measures. So use readability assessments like Flash Kincaid and Flash Reading Ease, which was what actually Zig Emanuel did in his study. And so essentially what these do, they are essentially formulas that look at the number of words as well as the sentences, so on and so forth, to come up with a score, and the score will tell you how readable or how complex your consent form is. And you've got things like readable.com, which is essentially this online platform that kind of concise everything into a single unified platform to do all your calculation. So that's on readability assessments. So I've mentioned to you, why consent is so important, what large language models can do to help improve the readability of your consent forms. But then that begs the question, is using GenAI really a silver bullet? I would say no, it's not. Because there are, as you may have well read in the papers, there are a lot of limitations in terms of GenAI. And what I'm going to share is specifically in the context of using GenAI to develop a consent form. So one, it can hallucinate. Basically, because of how the GPT architecture works, eventually there is always a possibility they can provide a supposed fact that's quite coherent, quite plausible, but it's actually downright wrong or non-existent. So, in this example, in May 2023, about a few months, I think 6 months after ChatGPT got released, this lawyer actually used research conducted by ChatGPT, and then it was found to actually contain citations that are just completely non-existent in nature. And then we've also got things like consistency. So essentially, it's called what I would term as performance drift. With every algorithm update, there's an expectation that the large language model is supposed to perform better. But unfortunately, that can never be assured. At times, it would miss the mark, and sometimes miss the mark really badly. So just at the start of this year in February, this was Google Gemini, where it created pictures of racially diverse German soldiers, which we know that's not true. And then very recently, I think in May, Google started to add AI into their search engine. And this was a case where the AI was actually suggesting to people, if your sauce of your pizza is kind of falling off, or I think your cheese is starting to fall off your pizza, add glue to your sauce. Yeah. And apparently this was actually picked up, I think, from a Reddit post where somebody actually asked a genuine question, and there was this troll that, gave a really sarcastic remark, add glue, it's going to help your cheese stick. Yeah. So you can see there's hallucination, there's consistency, and then there's also transparency, and this is in part is because, so there are a few definitions of transparency, and I'm going to define it here as it's because of the nature of the black box model, and also because of the GPT architecture and how it's actually being trained on a large corpus of text from the World Wide Web. So it actually cannot tell you where's the source or where's the reference, where is it coming from. So you can see that, coupled with this possibility for hallucination and performance drift, there's a questioning again, what's the validity and the accuracy of the output. So far what I've mentioned to you, has been rather conceptual in nature. So I'm going to flesh it out to you in terms of the practical aspect. So this is actually a case. So actually I'm involved in a study, and I've taken this. This is an excerpt from an inclusion-exclusion criteria for the consent form. I've changed some parts, but more or less it's, it's quite similar to the actual wording. It's small, so I will read it out to you. This study will include male and female subjects aged 60 to 85 with or without cognitive impairment, having intact decision-making capacity, and having no contraindications to brain MRI scans. subjects who are unable to read or write and those having serious neurological, psychiatric, or systemic disease will not be eligible. Also, subjects who are unwell on the day of the research visit will not be allowed to continue with any research procedures. Blood draw will not be performed on a subject with known history of syncope, convulsion, or any other adverse events associated with phlebotomy. Right, that's a mouthful, and you will realize intuitively by now that's just not easy to read at all. And that's just our own subjective perception. What do the objective measures say? So I use the same tools as Zig. And so essentially, it's rated to be of a college level, reading level, and it's really difficult. So, I put it into a large language model. So using ChatGPT 4.0, it took me more or less about 10 to 15 minutes, about a minute and a half to try to come up with a good prompt. And then the LLM gave it to me within about 30 seconds. And I took about perhaps between 8 to 10 minutes to kind of clean up the text to make sure what I want was in there. And immediately you can see, in terms of how the text, it's really clumpy, it's really all concise in the original, and you can see, the spacing done, it's not done by me, it's actually done by ChatGPT, and it's quite nicely put it out. And I'll read it to you. So this study will include men and women aged 60 to 85 years with or without memory or thinking problems who can make their own decisions and have no conditions that will make a brain MRI scan unsafe. You cannot join the study if you cannot read or write, have serious brain, mental, or other major diseases, are feeling very sick on the day of research visit. We will not take your blood if you have a history of fainting, seizures, or other bad reactions when having blood drawn. And so immediately you'll find that's really easy to read. And again, what do the measures, objective measures say? It's actually of a 6th grade level, so that's like in primary school, and it's fairly easy. So you can see, wow, within such a short span of time, you can come up with something way much more easier and understandable. But as I mentioned, there are also all these issues in terms of hallucination, consistency, and transparency. So what do I mean by that? So for one, it's managed to demystify contraindications with conditions that will make a brain MRI scan unsafe. Now, unless you're a medical professional or perhaps you're a radiographer or radiologist, you wouldn't know what does contraindications means. So for me, I have a background in life sciences, and also I have been with the DSRB Secretariat as well before reviewing medical studies, and this is a term not familiar to me. So I need to go and find out, I need to go and check with Google or maybe with a medical professional, what does it mean? So that's in terms of transparency, and then also in terms of in a way, not say hallucination, but again on transparency, it's not showing up right here, but one part of the original consent actually mentions systemic diseases. And then in GPT, it mentions major diseases. So are they the same? On first read, it sounds similar, but any medical professional would say, that's not quite the same because systemic diseases actually mean a disease that's affecting the entire body rather than a single organ or a single body part. And then on the point of hallucination, so again, sorry, it's not reflecting right. So in the original, it says unwell, but then in ChatGPT, it says very sick. Are they the same? I think I beg to differ. That's not the same. Yeah. So similarly, you've got contraindications. In the original, it mentions the word syncope, and then in ChatGPT, it mentions fainting. So again, you need to go and check, do they actually mean the same thing? Is the explanation correct? So what I'm trying to say at the end of the day is, that LLMs can actually free us from all of these lower thinking kind of skills, but then it cannot fully replace a human individual at the end of the day. These kind of errors will actually go undetected or unnoticed unless the user actually is a subject matter expert of the topic at hand. So what this means is, at the end of the day, you need to have a human in the loop. You are essentially using this large language model as a co-pilot rather than letting it go full auto and taking that whatever that's coming off from GPT to be the gospel truth. So essentially, you need to read, check, and verify what it's being said. So that's on GenAI not being a silver bullet. But what are the other considerations? So you may be thinking as researchers, okay, Joel says LLM is really good. I'm going to use it as a co-pilot, and I'm going to revamp my entire consent form. I would say hang on, hold on your horses there, because you would still want to align your consent form language and template with whatever that's been given by the IRB. In part, that's going to help in terms of your time to approval, because if the deviation is too significant in nature, then your IRB staffers as well as your IRB members are going to have to spend more time ensuring that all the required elements are in there. Whatever legal language that has been approved by the legal department is also in there. So that's for researchers, but then I would also suggest to the IRBs, perhaps now is the time to take this opportunity to, not just do a subjective measure, but also do a more objective measure, use Flash Kincaid to actually measure what's the readability, what's the understandability of your consent form templates. You want to do that to help your researchers as well as participants at the end of the day. And you find, it's just not readable, it's of a college reading level, then perhaps it's time to use large language models to help you in that process. So that's on consent form templates, but then what about other considerations? So there's this issue also of AI governance framework. Many academic institutions, universities would already have such frameworks in place for use of AI in education. But what about administration or research? Have your institution have policies that cover things like what type of large language models can be used? So there are a myriad of large language models out there in terms of them being free to use. They're open source, you can build it on your own, or you can use a personal subscription, or perhaps, everybody got MS 365 with their institutions right now, so perhaps can you use Copilot, Microsoft Copilot to do it? Or in terms of storing that data, must you store it offline, or can you store it on the cloud? And so that leads to the question also, in terms of data types as well as classification, what kinds of data and classification types can be put with these large language models, as well as how are you supposed to handle the data in terms of the inputs and outputs that you receive from the large language models? And so this is what a policy, AI governance policy would more or less cover. But perhaps you're saying to me, no, unfortunately, we do not have any such governance or any such frameworks. May I suggest to you then this is a time to approach your institutional leadership to consider setting up one. So you could involve people like your Office of Research, your IT, and legal, because using AI-informed consent forms is just going to be the tip of the iceberg. Consent GPT is one, and there's just, now with LLMs becoming so accessible, you're going to see AI being involved more and more in the conduct of human subjects research, augmenting the process instead of it being just an object of research. So a few other things to take note of. So data confidentiality, there's no assurances that whatever data that's being put in your large language model, for example, ChatGPT, it's going to be safe and secure unless it's homegrown or you have this enterprise or this contract, the institution with the AI developer. And you may say to me, oh, but ChatGPT has this function to switch off, to say don't record my responses. But then again, who's to say, big tech may always change their terms and conditions, right, their term of services, just like how Google is actually using whatever information you have on your Google Docs to actually train their Google Gemini AI. And then related to that, there's also industry-sponsored research as well. What are your sponsors saying, can you use LLMs? So if you recall at the start, I mentioned to you, regardless of whichever camps you belong to, I hope you are convinced that we should use GenAI in the development of our informed consent forms. And so this is what I've covered. Consent is important. In the primary interest of our research participants, you want to present them important as well as relevant information in an understandable manner. So large language models are be able to help us address these issues. So essentially, with that, you're going to be much able to closer meet this, I would say, this standard of providing a concise yet sufficiently detailed and readable consent form. But as I've mentioned, GenAI is not a silver bullet. You need to understand there are also these limitations involved. So you ought to have humans in the loop. And another thing to consider is policy considerations as well. Do you have an AI governance framework? So to my last slide, moving forward, you've heard me talk about the technology. If you've not tried it, may I suggest to you, it's time to try it. It's free to sign up, go and try it. No matter how much you hear from me, no matter how much you hear from the internet, from YouTube videos or from your friends saying it, it will never match the experience that you can get from using it. And this is what Ethan Mollick from the School of Horton at UPenn, he says that, try it out for at least 10 hours. And that pretty much matched my own experience. You need about 10 hours or so playing around with the technology to know what are the capabilities as well as its limitations. If you say, I'm not sure what to do, like how do I interact? There are a lot of information out there you can find. So this is one example. Essentially, what you put into that LLM, that input, it's called a prompt. Earlier on I mentioned about prompts. So it's called prompt engineering. And nowadays, you've also got LLMs that, in the interface at the start, they already have ready-made prompts that you can click and figure out how do you interact with it. And lastly, like I mentioned, AI governance committees. If you don't have one, perhaps it's time to start one. And IRBs, may I suggest to you, to actually get a seat at the table, to actually have your interests represented. The last thing you want is to have a policy that's so restricted that you're hamstrung in terms of what you can do with the large language model compared to your other counterparts. And at the end of the day, you also want to help your institutions ensure that there's this ethical use of AI in human subjects research. So this is the end of my slide, and thank you for listening.